Welcome back, everybody. My name's Daniel. This is the Righteous Monkey YouTube channel. Today, we're going to do something special. We have a special guest. As you know, I have 4 years. I'm sorry. Yeah, 4 years and 6 months of clean time sobriety. So, I'd like to welcome you guys, Dr. K, aka Dr. Thomas Kline. Here we are. How are you, Doc?
Good afternoon. I'm good.
Good.
And
Good having you.
thank you. I'm delighted to be here. You asked me to say a little bit about myself. I grew up in a log cabin. I had to walk 20 miles to school. I only had one horse. Oh, wait a minute. That's the wrong script. So I've been a physician for 40 years. And my specialty is rehab medicine, which I for myself. It's basically anybody with a long-term problem. It could be a kid, a baby, somebody 100. I've had patients 100. I've had patients in between. General medicine, I have not seen a lot of patients with addiction disease. So I need to learn more, and I'm learning from you guys. But I am a researcher in the field of opiates for pain and opiates that cause problems with people with addiction. So, with that, I think we're going to talk about a new name for opiate addiction disease. And it's going to be called receptor disease. This is the first time anybody has heard this, except for an addicted friend of mine up in Cleveland who spent 18 years on the streets addicted to opiates. After, at age 14, he was given 3 beers. So there is a little bit of a crossover sometimes between alcohol um, and opiate disease. But what we wanted to talk about today, and you're the first audience to hear this, is that the researchers at the two companies that I formed, one is called the National Pain Council, and the other one is called JATH, JATH, Educational Consortium, where we do research. And we have a research team of doctors and nurse practitioners and people who have a pain and addiction disease. And so we were doing this research, and I read, about all these people with RD, receptor disease, or heroin addiction, same thing. And I thought to myself, well, how many are there? So I go to a government website and it says there's 800,000. I'm like, God, that's a lot. But wait a minute. You can't just use numbers. I could say 2,500 people died in Montana. What good is that? We need to know how many people died per population. So there are 265 million people in the United States above the age 12. So I divided that into the 800,000 heroin addicts, and I came up with less than 1%. Now, wait a minute. All this hollering and yelling about so many prescriptions written, there's 200 million prescriptions written every year for opiates. And the claim is that they're addicting people. And I thought, well, gee whiz, that's not too many. So I was reading an article about the 1920s. The government passed the first restrictive law called the Harrison Act in 1915. And so the 1920s kind of became we got problems with these opiates. Opium and morphine was invented by then. And even heroin. Heroin was invented as a drug called diamorphine, which is used worldwide. It was invented to have less side effects than morphine. So those two drugs were being used in 1920. So in 1920, I read an interesting fact that 200,000 people were addicted to morphine and heroin. or diamorphine. We should be calling it diamorphine and morphine. I thought, good heavens. So I looked up the population. I multiplied it times 80%, which is the number of people over age 12. And guess what? 3 per thousand, the same as it is today. So wait a minute. The addiction in 1920 rate per person, rate, not total numbers, as it is today. What with all these opiates we're prescribing and people leaving medicine in their medicine cabinets. So then, as an epidemiologist, now epidemiologists are physicians and they track down epidemics. So in other words, all this COVID stuff and you read about it, that's all done by doctors called epidemiologists. So it had a disease that's this prevalent all over the population. Think to yourself, what kind of disease could this be? How about, let's say, a virus disease like COVID? That goes up and down. That doesn't stay the same. So, okay, what about poisoned wells? Well, no, that kind of goes up and down too, and it's regional. This is everywhere. You know, these were national figures, 200,000 in 1920 and 800,000 today. So then the question became, if I was a crack epidemiologist, I would say, wait a minute, this sounds like it's genetic. You see, the number of people with sickle cell anemia, which is genetic, is always the same per population. So then I started looking into it, and good Lord, I came across 600 scientific papers written about something's wrong with the genes in people with opiate addiction disease, receptor disease, none of the others. No genetic changes in people on cocaine, methamphetamine, alcohol, maybe some, I think maybe 5%. So wait a minute, if there's genetic research, then maybe this really is a genetic disease. Good Lord. You imagine the impact of that? What this means, you've got a disease that runs in families. That's nobody's fault. We have an interesting anemia in medicine called G6PD. It's got a longer name, but that's what we all say, G6PD. And you run around with this, with these genes, and nothing's wrong, nothing happens, your blood count's normal. And you go eat fava beans, and it triggers the destruction of your red cells, which is real serious.
Wow.
So that's called a triggered genetic disease. Whereas sickle cell anemia is always there. Hemophilia, it's always there. But the G6PD is a triggered disease. So if you keep eating fava beans, you're going to keep destroying all your blood cells. If you stop eating fava beans, you don't have the outward appearance of the disease. You still have the genes, though. And in medicine, we call it two different kinds. When you have a gene, it's called a genotype. And then the expression of the gene, in this case would be anemia, is the phenotype. It's, in other words, it's what happens. So looking into this more, 700 papers. The definitive paper was done a couple years ago by Taiwan researchers. They took 200 heroin addicted men and women, and they took 200 people called matched controls to kind of see what the difference was. And so they measured these genes, which you can do from a mouth swab. And in the 200 people without point addiction, guess how many had any one of the 18 abnormalities? None. How many had the abnormalities in the group of hardcore heroin addicts? 85%. So there's no question in my mind as a researcher, and I rarely get to the point where I'm 100% on anything. This is purely a genetic disease. Now, the flip side is if 1 or 2 people per 1,000 are carrying the abnormalities and become euphoric at their very first pill, 999 people will not become euphoric. Now, this is how it works. The addiction does not start on the first pill. The warning sign starts on the first pill, going to the moon. What the addiction is the second pill, and the third, and the fourth. Mm-hmm. So this has huge implications. Number one, people who have struggled for 10 years or more with opiate addiction or receptor disease, it was never, ever your fault. Never. This is a genetic disease, like eating fava beans. You know, it's not your fault. And so that's very, very important to understand, because there are Puritans running around saying bad choices. Well, this is why there's a difference between opiate addiction, which is genetic, and the other stimulants. This goes back to the days of the uppers and the downers. So heroin, the uppers are cocaine and methamphetamine, which are different. So we have two different groups of addiction. We have type 1, which is amphetamines, most alcoholics, and cocaine. These diseases do not generally have withdrawals. And the definition of this group is involvement with a substance or activity that ruins your daily life. Now, for type 2 addicts, addiction disease, which is opium products and nicotine, and we think maybe 5% of alcoholics. These are diseases that all have withdrawals, and they all have genetic connections. There is a genetic connection, believe it or not, for cigarette smoking. It's not quite the same as opiates. So we need to completely rethink, because number one, it's a genetically triggered disease. And so my question to all of you, if you knew ahead of time in school that if you took an opiate pain medicine and went to the moon, that's not normal. That 999 of your friends who took the same drug would not go to the moon. Would that have made a difference? Would that have been a warning sign enough that you would go, oh my God, I'm not going to go to pill 2. See, that's when the addiction starts, when you go to 2. So this is back to Nancy Reagan, right? Just say no.
Yeah. I remember, I'd like to thank you again for coming on. I remember when I was younger, and this came around the time to where I started driving shortly after 16, 17, 18. Every time I left the house, my mom always told me, don't do drugs. That was the last thing she said after she said goodbye. Just don't do drugs. And I always had that in the back of my mind, no matter where I went and who I was with. So, and from like brief commercials that I would see and like brief bits of information that I would see, that was never really enough for me to stop, or to not stop, but to try to engage in that behavior. So it's amazing to think. I don't know, even if I had all the information, I really don't know if I personally would have not tried it. It's pretty wild to think. It's pretty crazy to think. But before I knew it, I was hooked. It was too late.
Yeah, what if you specifically... Yeah. So, but if it's well known to the general population, to school counselors, to parents, and teenagers and doctors, then when the doctor gives you a prescription, we'll say, have you ever had an opiate before? And if you say no, then you say, okay, you got a chance of 1 in 1,000 or a little higher if you've got addiction in your
Wow.
family. That you're going
So,
to suddenly go to the moon with a cosmic experience. And that's why I need prescriptions from you guys so that I can teach other people that what it's going to be like if you're a teenager and you've got the genetic problem is what to tell them. You know, here's what you watch for. If you're right, this lead in taking illicit drugs and always have been.
yeah. So,
So you see, if we set up, go ahead.
to take it back real quick, like in elementary terms, basic terms, what does what is a receptor and what does receptor disease mean, basically, overall, in like simple
Okay.
terms?
Well, when I was in school, we didn't know about receptors, but what they are is picture a basketball and you've got the little area where you put the air pump needle in. That is that's like a receptor on the outside of your cells. Some chemicals like insulin are too large to just float into the cell. They have to be escorted into the cell. And what happens is insulin plugs into that little air thing, which we call a receptor, allowing the glucose to go into the cell. Hormones are too big to go into cells. So all the effects of hormones are going to be stuck into a receptor. Each receptor is different and physically different. So that estrogen and testosterone will have their own receptors. Insulin has their own receptors. And opiates have their own receptors. Why would the cell have opiate receptors? Well, opiates can't go into the cell. So they go into the receptors, like pumping air into the basketball, and they make their effects just themselves in this hole. It's actually a physical hole and it parks in there and it has to fit perfectly. So when it fits perfectly, the receptors are there for your own opiates, your endorphins. Endorphins, your brain actually makes morphine, that chemical, morphine. So it goes into the little receptor, into the opiate receptor, and it triggers the release of dopamine. Dopamine. Women who have the highest level of endorphins giving birth would never want to go through it again, right? Yeah, painful, you know.
Yeah.
So by having endorphins, they get rewarded with their own little morphine into the little receptors. And then they think, well, I don't mind having another one. Same thing after sex, after a nice dinner, after running, after working out. And somebody pointed out the other day, even having a bowel movement feels a little pleasant so that you'll keep doing it, right? If you didn't get rewarded, you wouldn't keep doing this stuff. So there are genes that control the construction of the little receptor. Just like in the basketball, they've got a mold somewhere that's making the little thing so the needle goes in, it doesn't leak air. So if you made a bad air point on your basketball and you stuck in the air needle, it would leak because they made the receptor wrong. So what happens in receptor disease, opiate addiction, the genes that construct the opiate receptors screw up. And the receptor is not constructed properly. It's just like building a house. You got to build it exactly right or it doesn't work.
Yeah.
So now, when any kind of opiate goes into the receptor and triggers the wonderful feelings of the dopamine, instead of, let's say, getting 100 units from your own endorphins after a good workout or a long run, you now get 10,000. huge in that people with the receptors not constructed properly experience. How's that?
Yeah,
It's not an
yeah, I hear
easy.
you. I hear you.
It's good. I present this to doctors. They just kind of look at me like I'm from Mars,
Yeah.
but it makes sense logically. It's Albert Einstein said once of his mathematics. He said, "You know, this may be not hard to understand for mathematicians. It's hard to believe." So you see, in our
Wow.
case, this is hard to believe. But
Yeah.
it will. This simple deductive logic can revolutionize the treatment of opiate addiction, but not the other addictions. See, that has to be a separate approach. And by the way, the definition we have for the type 2 addictions, nicotine, opiates, and 5% alcoholic, is, and this came to me from another person with receptor disease, it is intense seeking without regard for consequence. Opiate use disorder. That's statistics out of a list of 12 to make the diagnosis. Well, what is that? You know, I picked out several papers from this list, and they didn't really define a person with receptor disease. They defined people with pain disease.
Yeah, it's amazing, man.
So hopefully, go ahead.
Yeah, I remember the very first video I believe you watched of mine. I was talking about the the signs, or not signs, the symptoms of opiate withdrawal, and that's where you and I started talking back and forth, and then the more we communicated, the more I really understood what you're talking about. You know, I really don't understand everything as far as like the scientific, the whole anatomy side, but as an addict with experience and as well experienced I am with my body, you know, I really understand how my experiences and your information, you know, correlate, and it all makes sense with everything that you're saying. With all the research you've done, everything you're saying is making sense, and it's pretty amazing that as human beings, um, there is major differences in addicts and then normies, you know, people without the RD, without the receptor disease. So yeah, all this is blowing my mind. You know, I appreciate you coming on.
Yeah, for example, if we design the perfect rehab, and I would definitely like to hear from you folks, all of you need two different approaches. You need approaches for type 2 receptor disease addiction, and you need another different approach for people on methamphetamine and cocaine. Those you can't sit down with somebody with receptor disease and say, now, what was the problem in your childhood? You know, what a bunch of crap. You know, it's medical. You got to have medical treatment. But if type 1, if you somebody with cocaine, maybe the history of child abuse makes a difference. See, but the scientists currently and the people speaking on the issue use the word addiction by itself. Oh, he's addicted. Oh, she takes drugs. I'm a doctor. What drugs does she take? Makes a difference, you know? And so the same thing with addiction, the things that I'm pointing out to people is please use an adjective first. It's like diabetes. You got childhood diabetes, you got adult diabetes. You can't just say he has diabetes. You can't just say somebody has addiction. You either have a cocaine addiction or you have an opiate addiction or alcohol. You know, YouTube channels. You know, I'm getting that way. I can't stop looking at them. You know,
Yeah.
So, you know, And so we are separating out. Interesting that from a medical standpoint, like if you, let's say you were still, and we decided that this is what you have, and it needs to be medically treated with substitution treatment, then I would just prescribe methadone for you. That's the way it is in Canada.
Mm-hmm.
In the United States, because of the federal
Mm-hmm.
drug police and the separate licensing, if you came to me as an active heroin addict and I prescribed methadone to you, I would be arrested.
Wow.
It's against the law. So we need to do some work on the laws that are governing all this. And it's due to Richard Nixon. I'm sorry, the guy was a good president. He opened up China. He had good domestic policies, but he was paranoid.
Mm-hmm.
And he created all these laws out of his paranoia, thinking that people who took opiates or cocaine were all going to get him, turn into, dangerous people and get him. And all the left wingers, the hippies, and the people that he opposed politically all smoked marijuana. And by the way, I just have to say, if anybody wants to understand the culture and how we view addiction, you got to watch Reefer Madness, the famous movie from 1935. It was actually made by the federal drug police. Nobody knows it, but it is wonderful, interesting to watch. That's how it got into our fabric. And that's why people are crapping on other people with addiction, because of that movie.
Yeah. Yeah. And one last thing, the more that you and I communicated, got to know each other, I've always referred to the abstinence as being clean, as being sober. And you brought up a really good point that another good way to look at it is I'm sorry, there's like muffling in the back. Let me try something here. Oh, can you hear me? Are you there? Oh, okay. So yeah,
I am.
so another way to look at myself. What's that? We good?
I'm hearing you.
Okay.
We're good.
Okay. So you brought up a good point. Another way to look at myself as being clean, or people, with long-term sobriety. Another good outlook for that would be recession. My addiction is in recession, and yeah. So
Yes.
if you can go ahead and tell
Remission.
me more about that. Yeah, tell us more about what an addiction in remission looks like versus being clean.
Okay. Well, clean is a word from the Puritans, and sober is a word from alcoholics. And really, because receptor disease or heroin addiction is a real disease that can be seen under the microscope, has genes, has blood tests, that it's a lifelong disease. See, genetic diseases are lifelong. If you have sickle cell anemia, you have it for life. And you have receptor disease for life. Now, that means that you can take your fava beans and activate the disease anytime when you're 80. So technically, from the standpoint of a disease, when you're off your medicines and you're not currently actively addicted, the disease is in remission. And why we want to start changing words is because words carry meaning. And Kline, just the first time I heard the word clean, I thought, well, who's this? Cotton Mather, from Boston in 1690.
Yeah. Yeah.
Clean. I'll tell you something. That's if we don't change the words, we're not going to change the ideas. So, receptor disease is the addiction disease. It's opiate addiction disease, and in remission, I kind of like, but that's all up to you guys. I kind of like it from a medical standpoint because it means that if it's like cancer. If cancer's in remission, you don't technically have it. So if you relapse, you have your disease again.
Yeah.
So in cancer treatment, then you start some different kinds of treatment. And cancer relapsing is part of receptor disease, opiate receptor disease, as part of it. Mm-hmm. So you can't expect never to have relapses. Now, that's kind of hard to say because nobody wants a relapse. But if it does happen, then you treat the relapse. It doesn't mean anything else has changed. It doesn't necessarily mean the cancer is going to kill you if you relapse. You're going to take it on and take care of it. So when people relapse, and of course they feel terrible and they get all kind of negative comments because you're not clean. Mm-hmm. Well, actually, you just left being in remission. So now you're not in remission anymore. So you need to get back in remission. And so you treat the relapse. And I think I told you, I used to smoke cigarettes as a doctor. And it was very difficult for me to stop. It took me 9 tries. And I consider myself in remission. I mean, every time I smell cigarette smoke, it smells good, not bad. And I could just see myself starting up in 2 minutes, So it's a genetic thing. Remember, nicotine addiction is also genetic. And so I've got it forever. I'm guessing, and this is where I need input from you guys, that the strong desire, that's another word. I can't stand the word crave. It's just craven. A bad word. So we need to come up with a better word for intense like that. Back having an intense desire, that explains it all. You don't have to use the word craving. Yeah. But my guess is with talking to other RD people, it may last about 2 years. If you quit smoking, usually about 30 days out, you're in pretty good shape. But I think with opiate receptor disease, it may be a couple years clean, or is it better to have substitution treatment? From a medical, it's kind of like there's a drug people take for breast cancer that kind of holds it in place. Well, you don't want to stop that, even though it's just a pill, So you get 2 years out and the doctor says you're clean, then you can stop it. So that's a big issue that we have no answer for. We need information from you all about what's been your experience in terms of relapse. In how long out. But the point of what we're talking about today is a genetic disease. You will always have the genetic part of it. And the courage that it takes, I think people who quit smoking, I think that's a little bit of courage. But the courage that you guys have of, quote, staying clean or staying in remission is enormous. And you need to be praised for that. It takes a more than human effort to deal with this disease. It's a disease. See, that's the whole difference. And I think that, your programs are good because they're kind of having everybody pat each other on the back. But I've heard some negative comments from other YouTube channels when somebody relapses. Oh, Bob, shouldn't have done it, shouldn't have taken. No, wait a minute. Let's understand this as a disease. Said my part. And you see, I love having both of us up here because that's exactly what's going on. I'm doing medical research information. See, we can't do without each other. We need to understand what the medical science part is so that we can figure out a lot of other things. I will end by telling you a story that I could not believe. I had a paper from 1924 where they addicted a dog, right? By the way, dogs all that sniff at airports are all addicted. Anyway, so they did this experiment with his dog, and then he was addicted to opiates, and then the dog started to withdraw, and they took some blood from this dog, and they squirted it into another dog that was not addicted. And guess what? The second dog started having withdrawal symptoms. So the withdrawal may actually be biochemical. If it's biochemical, maybe we can figure out ways to make it less horrible. Because my guess, just listening to people so far, is if the withdrawal was like cigarettes, where you could just get through it in 3 days, I mean, a lot more people might be interested in remission.
Yeah.
I don't know. That's why we're here.
That is amazing, man. I could hear these stories all day long, and it hurts my heart that they used a dog. You guys know how much I love my dogs, and
yes, I knew
I
that was
couldn't
going to
imagine.
trigger something.
Yeah. My heart is. I'm crying inside right now. I would think they use like mouses or rats or something, but I mean, it for research wise, I could kind of see why it would be good to use something other than a mouse or a monkey, to see if this thing is truly real, to see if it's truly deadly. Why not try it on another species and,
Well, dog
proof is in the
research
pudding.
is pretty much dead. They're not using dogs anymore.
Yeah.
This was 1925.
Yeah, I hear
But
you.
I think there's with the border police addicting dogs so that they can sniff out heroin. I think that's terribly unethical. But anyway, we can save this for another show.
Yeah.
It's time for my donut.
Exactly. Time for my sandwich.
I get a donut every day.
That is the new nicotine for you. But thank you. Thank you so much for hopping on. If you want to check out more of Dr. Kline, go to www.thomasklinemd.com. We're going to be trying doing this more frequently. 1 week from today, we're going to be talking. We're going to be addressing another topic, another important topic. Also, one of my subscribers asked what the doctor's opinion was on medical marijuana, and we're going to be addressing that a little more in depth on next week's episode. So, Dr. Kline, thank you once again. I know we've had some technical difficulties with audio, but we're gonna. This is the first one, so we have a lot more time to perfect everything. So, once again, thank you, and we'll be in touch.
You're welcome. And if anybody has any questions that you would like discussed, send them into you. We'll have a website there, Daniel, somewhere, or email. But send us questions, because questions lead one to discovery. And I will see you next time.
Exactly. So yeah, if you guys have any questions, concerns, anything, any ideas for future topics, definitely let us know. My email address is righteousmonkeyofficial@gmail.com, and we'll be more than happy to take care of you guys. I appreciate it. Thank you.